Welcome to HN Oncology Journal Club. Today we're examining a review from the International Journal of Oral and Maxillofacial Surgery titled Neck Dissection in CN0 Oral Squamous Cell Carcinoma, a Chance for Immunotherapy. The central question: can neoadjuvant immunotherapy eliminate occult nodal metastases in early stage oral cancer, potentially obviating the need for elective neck dissection? The clinical context is well established. For CT1 to T2N0 oral squamous cell carcinoma, elective neck dissection improves overall survival by approximately 12.5% compared to observation, as demonstrated in the DeCruz trial. However, pathological examination reveals that up to 70% of dissected specimens contain no metastatic disease. These patients receive no oncological benefit while incurring significant morbidity, including shoulder dysfunction in 22 to 39% of cases. The authors propose a paradigm based on emerging immunobiology. Tumor draining lymph nodes harbor TCF1 positive progenitor T cells, which are essential effectors of checkpoint inhibitor therapy. These cells proliferate within lymph nodes, differentiate into cytotoxic T cells, and migrate to tumor sites. Critically, this immune machinery is preserved only in uninvolved nodes. Once metastatic colonization occurs, the lymph node microenvironment becomes immunosuppressive. The therapeutic implication is significant. Prophylactic lymphadenectomy may remove the very tissue required for optimal immunotherapy response. Conversely, patients with CN0 disease retain functional tumor-draining lymph nodes and may be ideal candidates for neoadjuvant immunotherapy. What does current evidence show for neoadjuvant immunotherapy in oral cancer? Single-agent checkpoint inhibitors yield modest pathological complete response rates of 0 to 17%. However, combination regimens demonstrate greater efficacy. The IMcision trial reported 31% pathological complete response with nivolumab plus ipilimumab. The Illuminate trial achieved 30% complete response and 60% major pathological response using toripalimab combined with chemotherapy. Notably, these trials enrolled predominantly locally advanced disease. The efficacy of neoadjuvant immunotherapy, specifically for eliminating occult micrometastases in CN0 patients, remains unproven. Three advances are required to translate this concept into clinical practice. First, improved nodal assessment. Current imaging modalities lack sensitivity for microscopic disease. Novel approaches under investigation include nanoparticle-enhanced imaging, photoacoustic tomography, and EGFR-targeted fluorescent probes. Second, risk stratification systems. Predictive models incorporating depth of invasion, tumor budding scores, and liquid biomarkers may identify patients with low probability of occult metastasis who could safely avoid neck dissection. Third, targeted drug delivery. Nanoparticle-based delivery systems and modified extracellular vesicles may enhance immunotherapy efficacy within lymph nodes while minimizing systemic toxicity. One registered clinical trial, NCT 0613-0332, is directly testing this hypothesis. It compares neoadjuvant immunochemotherapy plus observation versus selective neck dissection with 2-year disease-free survival as the primary endpoint. Results are expected in August 2027. In summary, this review presents a compelling biological rationale for reconsidering routine elective neck dissection in early oral cancer. Lymph nodes are not merely potential sites of metastasis, but critical mediators of anti-tumor immunity. However, this remains hypothesis generating. Until randomized evidence demonstrates equivalent survival outcomes, elective neck dissection remains the standard of care for CT1 to T2N0 oral squamous cell carcinoma, The full citation is Bu et al., International Journal of Oral and Maxillofacial Surgery, 2025. Link in the show notes. See you next time.